Welcome to INSHLT 2019, and we are with the Cardio Live. I am Dr. Bansidhar Trai. I am heading the microbiology and infection control at Max Healthcare Saket and overall in charge of PanMax. So, we have today our renowned professor Dr. G D Puri, who is heading the Advanced Cardiac Center at PGI Chandigarh, and the application of technology of anesthesia in the intensive care and world's first completed automated anesthetic delivery system has been developed by Dr. G D Puri. So, now I welcome Dr. G D Puri to our Cardio Live.
Good morning, Dr. Bansi.
Thank you.
All
good morning.
things.
Good morning and good. So, so this is our discussion on the infection in the transplant patients mainly. So, the first question to you is that what is your surgical prophylaxis for the heart transplant patients? It can be a surgical prophylaxis or it can be prophylaxis for the high risk infections like the pneumocystis or fungal infections or the CMV infections.
Dr. Bansi, routinely any cardiac surgery patients we do give surgical prophylaxis because we do not want the surgical site infections. Patients with the heart transplant is even more importance for this because if they develop surgical site infections post-operatively, they are going to be immunosuppressant. That is going to be a messy affair. So, that is going to affect the outcome badly. So, we have to be very strict and very clear in our management pre-operative as well as post-operative because of opportunistic infections also which can develop in these patients post-operatively because of immunosuppression, as you know. And here we do take help of your department of microbiology at our center and all the places wherever they do the transplant, they actively the microbiologist is involved in the both the pre-operative as well as the post-operative perioperative management of such patients, high risk patients. So, routinely what we do is cephalosporin first or second generation antibiotic we give. We add in these cases high risk cases vancomycin also, but it has to be given an hour or two before the start of the incision, before the incision to have the effect. Another problem which we face in transplant is that we are going to bring in the donor heart, and the donor may be also having some odd infections, and especially they are brain dead patients lying in ICU for a couple of days on inotropic supports and a lot of invasive lines. So, they may be infected with organisms which may be resistant to a lot of drugs. So, we take care of that. We do cultures, we do the procal, we investigate them, and based on their culture sensitivity we also use the antibiotics in the recipient. That is the primary thing. Now, the post-operatively because of immunosuppressive agents which they are getting, they are prone for this CMV, the pneumocystis, fungal infections. So, what we have found, or the literature has found in fact, that there is almost 30 to 40% of patients if not given prophylaxis for pneumocystis pneumonia, they will get this infection and which will affect the outcome badly. So, what we suggest or the recommendations are that these patients should be given trimethoprim from Soxazole, which is typically we have been learned as Ceftriaxone for first year. We give unaltered alternate day, and then regarding the CMV, we do serology of the donor, we do serology of the recipient. If the both are negative, well, things are easy, and
but the chance is less because it's the very high prevalence of CMV.
Yeah. So, if any of these is if the donor is positive, then we do give the antiviral drug, the Genfycyclovir, the Vincyclovir, and but if they are not positive, if the donor is not positive, then we test the viral load, and if the viral load weekly we test, if it increases, and then we give the drug. So that is about this.
So in fungal you do give some fluconazole prophylaxis? I don't know.
Well, there is the people. Some people gave, some people not gave, but the thing is, this is a very high risk situation.
Right.
Lot of immunosuppressants are given. The patients also may be on antibiotics before, like patients are in ICU. Even the recipient may be in ICU on the ventricle assist device, IV inotropes. So they may be having antibiotics. If they are high risk patients, there is no harm in giving amphotericin initially with or without fluconazole. The other strategy is to do the surveillance of these patients, the surveillance of the recipient regularly. Some people do biomarkers from the lung lavage, etc. So from the serum, but we are on the positive side that we do.
So depending on the immunosuppression.
Yes, yes.
So regarding CMV, I want to add on this on CMV viral load. So because of this, the CMV PCR, the real time PCR, the viral load, nowadays it is commonly monitoring, it is helpful in monitoring, and I think weekly or twice weekly you do the CMV viral load. So there is a cutoff, like we have a high risk, medium risk and low risk, like in any other organ, solid organ transplant patients. So usually preferably most of in Indian scenario there is a high prevalence of CMV. So recipients usually positive, donor or recipient, they are coming under intermediate or high risk. So usually we recommend 3000 copies as a base level for the starting of the empirical therapy, and duration of therapy depends on the initial viral load. If the initial viral load, CMV viral load is less than 10,000, the viral, then the treatment response is very good, even 11 to 14 days. If you give an injectable, in 11 days the CMV viral load will disappear, or 14 days in the oral therapy. So depending the initial viral load how it is, even less than 10,000, then the viral load response is the response of treatment is very good. Whereas if it is more than 10,000 copies, then the response is. But nowadays we are doing the real time PCR, not the P65 antigens which we earlier were doing, and it is readily most of the hospitals where heart transplant, where most advanced centers is having well equipped with the molecular test. So the CMV viral load is doing. Now the threat is that nowadays because of high immunosuppressions, so the transplant, and especially heart transplant which is very unique, you may face lot of challenges of Mdr infection nowadays in the tertiary care hospitals. Mdr infection like the CRE, carbapenem resistance Klebsiella pneumoniae, or the Mdr gram negative bacteria. So how you feel the difficulties in treating these patients?
I think this problem has become more prevalent in last decade, and especially some strains have been isolated from the Asian region, and these patients, both donor as well as recipients, may be harboring these organisms because they are in the hospital for quite some time before the organ is harvested or the organ is transplanted. So it's the challenge is how to minimize this Mdr or the carbapenem resistance of those organisms.
Right.
So what antibiotic stewardship is one way in which we can minimize this, like in addition to that, minimize using the drugs rationally, cleaning the environment, chlorhexidine bathing of both the donor as well as the recipient, and then if we are suspecting, like we can do the surveillance of both recipient as well as donors regularly, or for that matter all our patients in ICU, we can do that, but the microbiologist active involvement is needed in that, and if we can eliminate that, we should try to eliminate that. But if we are suspecting in a transplant recipient patient, then the use of proper antibiotic at the earliest is what is required. And as you know, even with the faster culture BACTEC, and then detecting the organism, finding the sensitivity may take long time, maybe 2 to 3 days. So anticipating, empirically starting, and then using molecular diagnostic techniques to diagnose, refute, or confirm or refute the diagnosis of this type of resistant organisms, and then escalating or de-escalating the drugs is what is required. But the issue is colistin is a nephrotoxic, and lots of patients may be having renal dysfunction preoperatively because of the low cardiac output, back congestion. So we have to be careful while using these drugs, both IV as well as inhalations.
Right. Basically, you want to say we have to be very careful when initially assessing the infections basically, and I think there is a paired blood cultures which usually we routinely send maybe every 3 days, 2 days, depending on the risk assessment, and a lot of antibiotics are available, but yes, we have a lot of resistance patterns. Some old antibiotics, like even sometimes the chloramphenicol, minocyclines, even now the ceftazidime avibactam is also non-NDM cases where more than 50% are even non-NDM cases are also, and you talk about the advanced diagnostics molecular platform. So now things are changing. We have a BIFAR also, where they immediately detect the pneumonia panel in 1 hour, the meningitis and the GI panels, and the blood panels also available. So it's all mutual clinical as well as microbiology. We usually take rounds, every day rounds to the heart transplant unit, the cardiac unit, and help clinicians as quickly, as earliest as possible, and guide them, because that is the main area where we all should help the patients and the clinicians. That is our motto of our clinical microbiologist.
Dr. Bansi, how do you rate this colistin vis-a-vis tigecycline in such patients, starting empirically?
Right, sir. So empirically, now the polymyxin, there is a colistin polymyxin debate, but polymyxin is also good because colistin is a pro-drug. So polymyxin is active drug. So nowadays focusing more of polymyxin B, 7.5 BD or as per the weight, but tetracycline we are restricting to the soft tissue and intra-abdominal. So tetracycline, but there is a minocycline is available, good penetration power, especially Acinetobacter. Minocycline is good, very good, and along with the sensitivity patterns, the culture is very, very important when monitoring, especially in heart transplant. I will say the paired blood culture monitoring at least 2 to 3 days or 4 days we should have sending this paired blood culture. That is very, very important. Now, sir, some other infections we can discuss, like mostly the CMVs, but there are some infections, nocardia, herpes, and some toxoplasma. These are the any infections which in other organ transplant patients. So that is, so it's basically the infections is very, very important. And so how, so anything on the vaccine part, how can we prevent all the vaccine if it is available? Should we give this to the heart transplant patients so that they don't suffer the infections and they will be on immunosuppression therapy?
Yeah, I think that's the vaccination has a great role. It's not only the vaccination of the recipients, but also vaccinating the healthcare workers who are going to take care, because if we can, the recipient is immunocompromised, so he is going to get infections from individuals around, even if those individuals are not suffering from the disease. So preventing the disease in the healthcare workers, vaccination of the healthcare workers looking after, that's the number one. Number two, as we know that these are immunocompromised, so once they are transplanted, and on immunosuppressant drugs, giving live vaccines becomes an issue. So, that is another thing, we cannot give live vaccines to these patients after the after the surgery.
Therapy, right.
Another aspect is that initial 1 or 2 months, maybe 3 months, they are on heavy immunosuppressant drugs. Immunosuppression induction is there. Right. So, and sometimes because of some doubts of rejection, they are escalated, immunosuppressant drugs are accelerated. At this point of time, giving any vaccine is not going to, the effect is not going to come as good. So, we try to use the waiting time of the recipients in vaccination, and we try to give vaccination in the period when he is waiting in the hospital or at home waiting transplant. So, that is the best time you can, whatever possible you can give, whether it is hepatitis A or hepatitis B in the usual schedule what we follow. And influenza vaccines also we can give live vaccines before transplant, but after transplant we have to give the killed vaccine only, influenza. And another MMR vaccine is another live vaccine which have to avoid post transplant. So, same with the testing the serology for the antibodies, and if it is negative, then giving MMR pre-transplant is another thing, especially in the childbearing age group of females who are requiring transplant. Then similarly those diphtheria, pertussis, DTaP, those are also post transplant usual schedule after 10 years. One another the finding is that in these transplant patients, the effect of the vaccination, the antibodies produced, also the duration is lesser as compared to the normal individual. So, they may require little earlier than what normal gap we provide.
Because especially I focus on the vaccine part, because after 6 months, then the community acquired infection will come up. The first 1 month the hospital acquired, then 1 to 6 months the reactivations of the viral infections, but after 6 months they will face the community acquired infection. So, that is the vaccine part is very, very important. And there are other infections like in heart transplant patients, like the Clostridium difficile infections, and sometimes infection associated diarrhea is also there is a challenge. So, in the Clostridium difficile, because of lot of multi antibiotics, because high risk patient they will receive multiple antibiotics. So, there is a Clostridium difficile infections, we recommend Clostridium difficile PCR, not for the routine serological test, because routine CAR test or the ELISA also the sensitivity is very less. So, in heart transplant or any other solid organ transplant patients, Clostridium difficile infection PCR we recommend, and plus the diet habit of the transplant patients is also very, very important. That should be initially period, because of lot of immunosuppressions. The diet should be a proper diet, should be the water, mineral water should be proper, our water should be proper, the cooked food should be proper, otherwise they sometimes cause diarrhea in transplant patients. So,
instead of asking the patient in the initial phase to have the tap water, they should have the boiled water.
Definitely the boiled water,
because we are not sure what is lying in this bottle. You have to, the boiled is the best thing.
Yes, sir. So that is another important subject, and we have you are talking about the most molecular advanced technique. We have a biofilm GI panel. The GI panel, especially we have seen there are almost 22 pathogens can detect in 1 hour, like the Campylobacter or the Rota, all viruses, all bacteria, even parasites. Cryptosporidium also, there is a few cases of Cryptosporidium reported in heart transplant patients. So, all can be detected in 1 hour. So, the advanced technique is very important. The role support of clinical microbiology is also important. Definitely the clinician is the hot seat and he has to manage, but as a lab point also we have to support in every aspect of the heart transplant patients, so they do not have an infection.
I think is the teamwork. Yes. It is not the surgeon, it is not the physician who brings the transplant recipient, and not the intensivist who is treating the donor, but the teamwork where the microbiologist is a very key, involving at the slightest doubt of any infection, so that he can come in and take some samples for and prove prove or disprove the suspicion which the clinician may be having.
So thank you, sir. Sir, just we have 1 minute for the break. So before, I just want to ask the final question. So how overall you think the infection in heart transplant patients, how challenging in 1 minute only?
Well, the infection rate is high because of venosuppression, but it is relatively lesser than the lung transplant.
Yes.
And so the advantage is there, but definitely the precautions needs to be taken right from the time patient is put on the list, transplant list, and similarly we at our place, we put lot of effort in the donor management, because the recipient is still has been under your control most of the times, the donor has not been. So detecting the problems the donor at the right time and giving the drug to the recipient as well as donor, treating the donor at the right time, that is ultimately affect the outcome.
Thank you,
we
sir.
still get 10 to 20% of the patients who do get infections in the heart transplant.
Thank you, sir. Thank you very much.